Here is your question. Right, so if you have read and understood, considering the communication skills station, kindly begin.
Hello, my name is Dr. Ali. I am part of a surgical team that has been managing you. Can I confirm your name, please?
Yes, my name is John.
So, John, I have been told that you have requested for a discharge. Is that right?
Yes, doctor, I want to go to home.
Okay, I'm here to talk about that. But first, I would like to ask that: do you know do you know about your condition and how it has been managed up till now?
Yes, doctor, already one of your senior told me that you are now stable. So I don't think I need to stay in hospital anymore. So that's why I'm going. I want to go.
I understand that someone has told you that you are stable, but the thing is, you sustained an accident and that caused a fracture of the rib just above the spleen. And we have managed you, although there is blood loss that can be seen due to the blood reports that we have received. And although you are stable right now, but there is significant chance that you might bleed from this spleen. Do you
Yes,
understand
doctor,
that?
but I'm not comfortable here. It's so disappointing and depressing environment over there. So that's why I want to go to home.
I understand your concern that you are quite uncomfortable and frustrated, but we only keep the patients in hospital if there is a specific reason for them to be kept. Is there any specific reason you are not
Yes,
comfortable
sir.
in the hospital?
Yes, a lot of work I have to be done at my home, and my wife has also some medical issues, so that's why.
I'm so sorry to hear about your wife, but the thing is that it's your health. If you are not healthy, then how will you be able to take care of your wife? And
Yes,
the
you're right,
second
but
thing
doctor,
is, yeah, the most important issue here is that currently your condition is stable because the blood is collected inside the capsule of the spleen. And God forbid if that capsule ruptures, then you may suffer a massive bleeding at any time. And that's quite a considerable risk for your life.
but do you think how many chances are there that I will deteriorate or my health will be deteriorate? I don't think so because
Yes,
I'm quite stable now.
although the chances are small, but once it occurs, it will be very difficult for us to manage that. And that's quite significant amount of danger to
Yes,
your health. Yes.
yes, doctor. But I have also job interview as well day after tomorrow. So if I will stay here, so how can I will go over there? It's
I
so
understand
difficult
that
for me.
job interview is quite important for you, but even if we can help in this sense that I can request my consultant to give you a letter or contact the interview and provide the evidence that you are having this genuine problem and you need bed rest in the hospital. So will that do? Is it going to help you if you provide an evidence and talk to
No, no,
your
doctor.
mm,
No, doctor.
so okay, just
It's
in
not
case
enough.
that you have made up your mind, it's very important for us to sign a legal document that you have been explained the risk and consequences of self-discharge, and in case of any complications, you are going to be responsible for your condition. So are you going to sign that
Yes,
document?
sure. Yes, sure. I will sign.
Okay, I will get the documents for you. But one important thing, in case you suffer any sweating, pallor, or abdominal pain, it's my advice to immediately contact the emergency, because it may be a life-threatening situation at that moment. Is it clear to you?
Yes, doctor. It's quite clear.
Okay. So now that you are going to self-discharge yourself, can you summarize all the important points that we have discussed till now?
Yes, doctor. You can summarize.
You will
Yeah.
get patient.
Yeah. So we have discussed your condition, and I have told you about the problem you are having with your spleen. There is a possibility of bleeding that can endanger your life at any time. And not only that, you have not only you have realized those complications, but you are also willing to take any risk. And we are going to sign a legal document that's going to hold you responsible for any consequences that happen from now forth on. And we have also discussed the danger signs that you might experience in case of a rupture. And my advice is you to follow in emergency in case you suffer any emergency. Is that clear?
Yes, doctor. I got it.
Okay, I'm going to give you a contact number, and you can take the contact number from our staff. And at any point you need any help, or you have any query, you can contact on that number.
Okay, doctor. Thank you so much.
Thank you.
You still have time left. How would you expand it more? 2 minutes are still there. All right, we can discuss. What have you missed? Yes.
He did not offer to help because one of the patient mentions that his wife is having some kind of trouble.
Yes.
The candidate must have offered the help from social workers at
Yes.
that point of
Yes.
time.
Yes. And yes, Dr. Mohammed Ali, you can cover now. You can tell what would you have done. What would
Yes,
you have
ma'am.
said?
I would have offered some social services
Yes.
that he can stay in hospital, and we
Yes.
can offer social services
Alternative,
for
yes.
care of our wife.
Yes.
Yes.
And
Yes.
what about the interview, which is in another town?
Yes, I tried to make comment like we can talk to our consultant and we can provide you with a letter that you can present to the interview, and they can make a later date. They can postpone the interview. So in that case, you can be provided a second chance for interview.
Yes.
I
And
told about that.
the sign and symptoms, you also told the red flags that if something happens, you can come to emergency A&E department.
Then
immediately. Yes.
yeah, one more thing you should have added is to acknowledge the patient of the importance of the spleen. What is it? Where is it? And what does it do in our body? It executes certain vital functions. It is in
Yes.
the tummy. It is on the left
Yes.
upper side.
Yes.
So that he gets an idea where he is.
Yes.
Yes. And why is it important that you have to, yes, observe? And the hemoglobin also drops. So that
Yeah.
you also have to emphasize and explain it to the patient.
Once you get
Yes.
okay,
Yes,
so
please. Yes, please.
once you get to the discussion of talking to the patient about his
Yes.
condition in the first instance, that should be your last line, that your HB has dropped, your blood has dropped by 1 gram. That gives the possibility of continuous bleed, and that can really lead to deterioration and endanger your life. Then you will need to sit up and patient will think.
Yes.
Yes, but the drop in hemoglobin is because of the hematoma, right? And somebody
Yeah.
has also already told him, yeah, like he said that somebody told me that I'm stable. Now, how can we repute with this?
No, it will
somebody
be
is
like
lying. So
patient
yeah,
itself feeling that patient is stable.
He is himself feeling that.
No one has told the patient. Patient himself has decided that patient is okay, and now patient will go home.
Mm. Okay.
Yes, Dr. Abbas, yes, please.
Okay, thank you very much, ma'am. I just have a few things to say,
Yes.
and then good job, Dr. Muhammad Ali.
Yes.
But it was good. It
Yes,
was
it
good.
Yes.
was good. Yes, thank you. Yes, it was
However,
good.
I just have a few things to say.
Yes.
For these particular communication stations, the demand communication stations that you have to communicate with the patient, you have to try to act as much as you can, meaning
Yes.
that you have
Yes.
to express, you have to be, your voice has to carry some expressions, convey some expressions to the patient, for the patient to feel you have a lot of empathy towards this illness, for you to feel how much you understand, how you that you are trying to understand what he or she is passing through. So that's one thing. Then two is that if the patient eventually decides to sign a DAMA, you have to assess for capacity, meaning
Yes.
that you have to ask the patient to summarize all
repeat.
what you have
Yes.
discussed,
Yes.
because so that that way you will be able to the patient will give you feedback, he gets clear understanding, and then you will tell him, okay, for after you've been able to repeat back all we've discussed, I've been able to assess that you understand all what I have told you. That is when you now come and say, okay, then I'll be giving you a form to sign. However, anytime you feel this particular symptoms, you can always come back to the hospital. I would leave my number with the nurses just in case you change your mind, because you still have to give the permission for allow the patient to time to change his mind, just in case you change your mind and you don't decide to leave anymore, or you I'll leave the form for you to go through it, and then just in case you change your mind, I'll leave my number with the nurses, and if you have any questions, I would also you can also call me, so that way you can close your discussion that way, so that it will be easy. The examiner will understand that you don't want the patient to go. However, for example, the exam I did, my patient did not leave. And that was because I was able to convince him. I had this patient. And that was because I was able to convince him. I told the patient that I'll be going for, I will be helping him set up a remote interview session, so that I'll discuss with the employer for the possibilities of setting up a remote interview session, so that he can still have his interview while in the hospital. Then I told him that we can also, there's a shop, a gift shop in the hospital that sells bouquet of flowers and gift items that he can send to his wife, and then just to make her feel better since she's alone. And then we can arrange with the social workers to get someone to take care of his wife, so that she will not be lonely. So those are some of the few things you can say. And then you have to carry a human face to it. You have to tell the patient, I know, I'm so sorry about that. I know, I'm sure your wife is a bit lonely, because my patient told me that it's just him and his wife. There's no other person on the home front. So that's another thing you have to ask. Immediately he tells you, okay, I have a wife who has a breast cancer, who has just been diagnosed of breast cancer, and she needs a lot of care. You ask him, so sorry about that. Is there anyone else with you on the home front, aside your wife, that can take care of her? If she says no, he says, so sorry about that. I'm so sorry. Then it's possible that we can arrange we can call the social works department and arrange social workers to help take care of your wife, pending when you get better and go back home. So these are some of the few things you can add to what you've discussed, so that it will be more interesting. Thank you, ma'am.
Yeah, thank you. Very good feedback. Very nice.
Yes, Dr. Faria.
Yeah.
Yes, please.
One point, although he did a very good job,
Yes.
that when we are telling the patient about the red flags, we try to use the layman terms like like abdominal pain, so we can use tummy
Tummy
ache,
ache.
or
Yes.
and pallor, yellowishness of skin, or
Yes.
something like that.
Paleness. Yes. Yes.
Yes.
Yeah. Good. Anyone else? It was good, Dr. Muhammad Ali, but yes, like
ma'am.
they all told you, room for improvement is always there. That's why we are practicing.
Yes, ma'am. Thank you.
Good. Good. Thank you. We didn't ask Dr. Saddam, how was his experience? if he wants to give any feedback.
Ma'am, I think he was very good.
Yes.
He was quite calm and sympathetic towards the patient.
Yes.
So it was overall good.
Yes. How did you feel the communication was going? You two were getting along well, like communicating systematically or rhythmically. Yes. Good. Thank you. Your timer, and here is your question. Yes. Right. So if you have read and understood, considering it history taking station, kindly begin.
Okay. Hello, my name is Dr. Saleha and I am one of the exam candidate today. Can I confirm your name and age, please?
Good.
Yes, I'm John. I'm 54 years old.
Okay, nice to see you, John. Today I have been asked to take history regarding your medical condition, and for that reason I will ask few questions. Is that okay with you?
Yes, doctor.
Thank you so much for your cooperation. So, Mr. John, can you please tell me what bring you here today?
So, doctor, I'm having difficulty in breathing since last 6 weeks, and it's increased recently. So that's why I came here.
Okay, I'm so sorry to hear that. Can you please tell me more about that? Is it you told me that it started 6 weeks ago. So it was a sudden or it gradually come? Like, can you please tell me that?
It was gradual, doctor.
Okay, so it's increasing or the decreasing? What's the trend of the shortness of breath?
Yes, it's increasing, doctor.
Okay, so can you tell me what you do to like in which it increases, like it is increased by walking or doing any exercises?
Yes, doctor. Previously, it was there when I used to exert a lot or after walking, but nowadays, even even at sitting normally, it is there. Even at resting, I have difficulty in breathing.
Okay, and so what you do for to relieve your distress?
So I change my position, doctor. I sit upright and I try to take deep breaths.
Okay, do you take any medication for that?
Yes, doctor. Actually, I have been prescribed some medicine from my GP, but
Okay,
it is not effective.
so do you have any kind of pain as well?
It's not pain, doctor, but I have some discomfort in my chest.
Okay, and what about cough? Do you have cough as well?
No, doctor.
Okay, and can you tell me like how it affecting your day-to-day life?
Yes, doctor. It is. If it is, I'm like my day to day. I'm not able to do any of my work, routine work. I need assistance all the time. It's very difficult.
Okay, I'm so sorry to hear that. Mr. John, along with breathlessness, do you have any kind of fever?
No, doctor.
Okay, any chest pain or any epigastric pain?
No, doctor.
Okay, so how many? So tell me about your sleep pattern. Is it normal?
Yes, doctor, but nowadays it's very difficult to get me quite sleep.
Oh, I'm so sorry to hear that. I understand it will be very difficult for you. So how many pillows do you use at night?
I use one or two pillows.
Okay, so do you ever have any episode of gasping at night for which you have to get up and take deep breath?
No, no, doctor.
Okay, so tell me, do you have any kind of pain on the chest, like it increased by taking deep breath?
No, doctor.
Okay, that's nice. So, Mr. John, if you don't mind, can I ask you further questions regarding some personal questions as well?
Yes, yes, doctor.
Okay, thank you so much. So, tell me, apart from this condition, do you visit your GP on regular basis?
Yes, doctor. I have some problem with my lungs. I don't know exact name, but they are giving me medicines for that. It's a long-term disease.
Okay, and do you have? Tell me about your weight. Is it the same, or like, do you have any episode of weight loss recently?
No, doctor.
Okay, and what about your appetite?
It's normal, doctor.
Okay, so you told me that you have some lungs issue. Did he prescribe any inhalers as well?
Yes, yes, doctor.
Okay, can you name your medicines?
Sorry, I don't remember the name exactly, but
Okay,
yeah.
it's totally fine. Okay, do you have any history of other medical conditions like blood pressure or any diabetes?
Yes, doctor. Recently, just 4 months back, I've been diagnosed with some clotting issue with my blood, and they gave me medicine for the same.
Okay,
It's
so
continuous.
okay, are you regular with the medication?
Yes, doctor. Yes.
Okay, do you have leg pain with the cough?
No, doctor.
Okay, so do you have any past history of surgery recently or like a few years back?
No, doctor.
Okay,
Can
tell me
you
about your
summarize your history now, please?
to complete my history, I would
Yes.
like to ask some personal questions regarding her work as well as your physical activity, and I will also like to ask her own perception about her disease and her systemic inquiry as well.
Yes. Can you summarize the history now, please?
Okay, Mr. John, a 54-year-old patient presented with 6-week history with the dyspnea, which is gradually increased in the onset, and she has a difficulty in the sleep as well.
Sleep.
And
Yes. And
my history is incomplete, basically.
that's all right. But the presenting complaint that you asked, patient has complained of shortness of breath, and there was no acute chest pain. And what are your differential diagnosis for this patient?
My differential diagnosis is pulmonary embolism, as the
Yes.
patient is on taking some blood thinners,
Yes.
and it might be a myocardic infarction,
Very good. And
any
Any other-
lung malignancies,
okay. Any other common condition?
and a musculoskeletal, any history of the trauma and something
Okay.
like that.
All right.
Yeah.
Could even be acute exacerbation of COPD because patient is a known case that you read in the stem. Okay. How or what investigations would you ask for to confirm your diagnosis?
Well, I will do some blood investigations, like
For example?
I will I will do PTA, PTT, INR,
Yes.
clotting profile basically,
Yes.
and blood CP,
Yes.
and I will do the chest X-ray, ECG,
Okay.
and if I'm suspecting pulmonary embolism, then I will go for the CTPA.
Yes.
ABG is also important in
ABG
this
is
case.
also important. Very good.
Yes.
So what is the mode of, what is the management or what is the treatment alternative that you can offer to the patient? Considering patient has presented with increased
yes.
dyspnea. Yes.
Well, as we will start with the heparin, and
before that, because it's an
Before-
emergency case, it came in
Okay,
ER, so you'll
okay.
begin with ABC.
Yes.
protocol.
Yes. I will manage this patient according to secret protocol
Yes.
and with the ABC approach, and I
Yes.
will look for the airway, and
Since,
I
yes,
will
patient is
check the
talking,
airway.
so yes.
And patient is talking, it means it's normal. Then I will go for the breathing. I will inspect. I will do inspection, palpation, and I will auscultate the chest as well.
Yes.
And I will check the through spirometry. I will check the saturation.
Yes.
And if
Now
required,
tell
then
me about that APTT and heparin and all that.
yes,
If
ma'am.
it is, yes.
And then if the saturation is normal, then I will go to the circulation, and in this I will send some blood investigations, and in AB I will send ABGs and all the required clotting profiles, and I will start with the
Okay, just suppose if it's pulmonary embolism, how would you decide which management to give? Considering it's, yes, non-massive pulmonary embolism, or if it's massive pulmonary embolism.
Okay, for the non-massive, I will go with the heparinization of the patient. I will give 70 units at the bolus, and will do 15 units per kg per hour until APTT is like 50 to 60. And then if it's a massive, then we will go for the thrombolysis.
Okay, good. Can you tell me when would you categorize it as massive?
We will categorize if if the patient is hemodynamically unstable, and if the patient is not responding to the medical treatment.
In how long? You have to tell. You've
And
applied,
we will
and for how long you'll wait, and then you'll categorize it, or you'll consider it as massive pulmonary embolism.
we will see the CTPA as well, and secondly we will wait for like 4 hours, 2 to 4 hours.
Yes, 4 hours. Okay, good. Yes, yes, thank you. Bell has gone, but we were just discussing. So, Dr. Snell, can you give feedback, please?
Yes, ma'am. Ma'am, it was very, very good history.
Yes.
She covered almost
Yes.
all the points which were important, and all
Yes.
the differential diagnosis as well.
Yes.
And yes, ma'am, she did very well, ma'am.
Yes. What was the point of improvement? Because when she summarized it up, one thing that she did very nicely, she remembered that I tell everyone the points that you have forgotten or you couldn't cover because of the time shortage. Did she mention all of them? I don't think so. Yes. Yes.
She should have mentioned, because she mentioned about the weight loss and appetite as the
Yes.
personal history. It
Yes.
is not in that. It is
No.
just while you are assessing the chief complaints, you
Yes.
have to take the history there. You are excluding carcinoma in that scenario. So
Yes.
this should have been asked in the main differential diagnosis.
Yes.
Second thing is that she could have also added if movement is exaggerated by, if movement exaggerates the pain, or pressing on the chest
Yes.
increase the
Yes.
pain, that is musculoskeletal differential of it. Then
Yes.
she should have asked about the anxiety. Does the patient get these attacks
Any stress?
associated with any
Yes.
kind of
Yes.
stress, something?
Stress or anxiety.
But
Yes.
almost she has covered too much of it. It was nice, but yes,
It
time
was
management
nice.
is needed.
Yes, and then she already herself knew that presentation, which I always say, that the summing up of the history in the 30-second, that should be strong, and she herself realized that she needs improvement over there. Good. So this is my message, that whatever history you take, then you should be able to know what would be the findings that you have to summarize at the end, and that summarizing or that summary should be strong, because that's when you'll be getting or receiving marks for that summary that you tell.
Okay.
Yes, please. Yes, please, Dr. Santosh. Yes, good evening.
Ma'am, the summary should be after the systemic review, you're saying?
Yes.
Summary's
When bell
presentation
goes,
to the patient.
yes, yes.
So,
Summary
so
is the
some,
presentation of the history.
yeah, that summary has to be told after the systemic review. Then
Yes.
you will tell, and then you will ask patient, is there anything to add or is there any questions? Then you will close the consultation with thank you.
Yes.
Is
I
that
No,
am-
it
correct,
is
ma'am?
Yes, yes.
no.
But I'm
Ma'am is
asking.
pointing that summary is the presentation to the examiner, because you will be having
Examiner.
separate marks for that. Once you will
Yes.
present the history to examiner, that is the presentation. That is
Yeah.
what ma'am means.
Yeah, that's okay. But I
Yes.
want to know, like, summary for the patient comes after the systemic review.
Yes.
Will
Yes.
some the patient, okay, you have got this and this and this and this since this and this. So what we are gonna do is we are gonna see, we'll run some test and see what the cause for the problem is, and we'll get back to you. Is there any questions to add? Thank you.
Yeah. This
Yes.
is the end.
This is the actual way of closing the history. But Dr.
Discussion.
Santosh, sometimes you don't get to that point when you say, okay, thank you. If there's anything else you have to add. But bell
Ma'am,
goes, right? Bell goes. Now you're facing examiner and you have to summarize to the examiner all the 6 minutes, whatever you've done with the patient. So we were discussing that if in this case or in any cases, you have to work on that 30 seconds, that once you have to summarize it to the examiner, that summarizing, that presentation should be strong, because then only you'll be given the marks. If your summarizing or your summary to the examiner is weak, you lose marks.
okay. Ma'am, in presentation, should we say like, we'll tell the positive findings like this and this 50-year-old son
Yes.
comes
You will
with
tell the positive findings and you will exclude some important
The
negative
negative,
findings.
important negative points as well. Like you
negative.
can say there
yeah.
was no pleuritic pain, so that was negative. In addition to you told, so there was no intentional weight loss or unintentional weight loss. There was like something that you are telling to rule out your differential diagnosis. So if there was no weight loss, that means the lung cut.
Or rather than telling like pleuritic chest pain, weight loss, can we say like no history suggestive of pneumonia, no history suggestive of carcinoma in the lung? Is that right?
Because 6 minutes are very less to make such big statements. I will tell you one thing you will remember. Once you take the history, chief complaints, you have to keep something in mind. Like Dr. Maimuna did right now, she tried to exclude carcinoma, musculoskeletal pain, MI, then chest infections, PE. Once you are presenting the case to the examiner, you will bear these things in the mind, because you know there is one particular diagnosis to which the case goes. For rest of the things, you will say 2 or 3 points which will exclude MI, which will exclude carcinoma, which will exclude pneumonia. You will say there is no history of VG chest, no history of fever, no history of unintentional weight loss or change in the appetite. That will itself exclude the bigger things.
Okay.
Keep differentials in mind. And exclude them with 2 or 3 pointers one by one.
Okay. During presentation, the main positive history will tell, then we'll tell the negative history, significant, if any significant past history or family history, and if any significant
you have to mention that.
history,
You have to
any
mention
significant occupational history, then is there any idea concerns? Is that correct?
Yeah, that is very important.
Okay.
Yes.
Okay. Thank you, ma'am. Yeah.
Good. Thank you.
I have one question.
Yes, please.
As when I came to the personal history and the GP thing, and she said like, I have some lung disease.
Yes.
After that, I asked about the weight loss, and in the previously I thought like it's not important because it's just a 6-week history and I don't have time to exclude it. Basically what was in my mind. But when she said like I have some chronic lung issues, then I thought like I should exclude it as well. So it's a good thing, or should I not take it in the systemic review?
the fact is that you were mixing presenting complaint with the systemic review.
Okay.
Yes. So first you complete the presenting complaint. You have to read the order, like do it in the order. First read the presenting complaint, then rule out all the differential diagnosis. Then you move on to the next. Okay. current
Family
or-
history, drug.
Yes.
That is the rest of them.
Then medical or surgical history, then family history or social history and drug history and any surgery.
Yeah.
And at the end, idea, concern, and expectations. Once
Yes.
this
You-
is
you-
done, then systemic review.
You need to have a quick script of those things: family, social,
Yes.
medication, ideas, because this is all the same for everything. The
Yes.
main thing is presenting complaint and excluding other things. That should take 3 minutes.
Yes.
Okay.
And one thing that this patient, you didn't ask about the dyspnea, like if there was any relieving or exacerbating factors, and if it is
No,
associated with the
no,
pain.
sir. She asked it in a different way. She asked
Okay,
if
she
patient
did,
is having
yes.
any drugs or any other thing
Yeah.
for it.
Right. But then you had to ask about the pain as well, like grading and.
Ma'am, it was
Yeah.
like not pain, so I didn't ask for grading, but I just asked like how it's
No, the
affecting the
timing,
day-to-day.
sorry, the timing of the dyspnea, like what time
Is
the
there
patient
any
has it.
particular time of the day
Yeah.
your breathlessness increases, your discomfort increases?
This is
Because
what I
if she
mentioned.
or he says that it increases during night while lying down, extra, you can have
Yeah.
different idea in the
Night
mind.
she asked again, that I
Yeah.
remember. She made it clear that patient doesn't have nocturnia. Or
It has to be bit specific, otherwise you ask good things.
Yes. Good.
Okay.
Good. With practice, you'll be good. Don't worry. Good.
Thank
Thank you. Thank you.
Thank you, everyone.
Thank you.
ma'am.
Started your timer, and here is your question. Right. So if you have read and understood, considering it clinical examination station, kindly begin.
Okay, good evening, ma'am. Good evening, sir. I'll come into the room. I'll wash my hand and introduce myself
Yes. Then.
to the patient. Good evening, sir. I'm a candidate in this exam. I've been asked to examine you. It will involve me at your filling it and then moving some parts of your leg and then giving you a few instructions to carry out, if that's okay by you.
Yes.
Then I'll continue. Okay. So I'll expose the patient. I'll tell the patient to remove his trouser, leaving his briefs on or shorts on for dignity.
Yes.
Then I would then tell the patient to stand, and then I will inspect the lower limb, both lower limbs. However, I would pay more attention to the right side. I will check
Yes.
for presence of scars. I will check for presence of muscle wasting. I'll check for presence of fasciculations. I'll check for presence of abnormal. I'll check for presence of articulation, muscle wasting. I'll check for the abnormal dark discoloration, hair loss, or
Who is turning papers? Tell without
abnormal-
looking. Yes.
No, I don't know who is there. It's not
Okay.
me.
All right. Yes.
Yes, ma'am.
Yes, please. Then what would you do next?
Yes. Then following this, I'll then ask the patient to walk. I would expect page, following which I would also inspect while lying down. Then I'll check for I'll palpate for temperature. I'll, before this, I'll also look around for walking aids like crutches.
Yes.
And then I'll palpate for temperature around the knee joints, especially around the areas of the scalp. And both normal, and I'll start from normal, then I'll check for abnormal. Then I'll check for nerve. And then I'll look in the ulcer or any other lateral side of the region where I expect the common perineal nerve to be located, and then and I'll check and I'll ask the patient if he feels any. I'll first inform the patient that I'll be hitting your leg around this side, and then if you feel any shock sensation, let me know. And then I'll also check for sensation. The next check for sensation. I'll do both the pinprick and the light touch sensation. Pinprick will check for your column, anterolateral column, and the light touch check for the posterior column. Then I'll then start by telling the patient to straight leg raise both the lower limb, starting from the right side and the left side. And then I'll tell the patient to that's what else to I'll assess for knee flexion and then knee extension. I'll assess for to raise the ankle, to lift the ankle up against himself. Then I'll tell the patient to down the foot as if it's matching on the hip. Then I'll see if he can also do that against resistance. Then I'll also assess the big toe. Before the sensation, I'll check all the modalities from L1 down to S1. And then I'll also check at the region of the interspace between the big and the great toe to rule out loss of involvement of the deep peroneal nerve. And back to the motor, I'll check for then after in both lower, meaning that I'll tell the patient to put the heel over the contralateral shin and then move it downwards along it to check if to see if there will be any abnormal movement around that. Then I'll also tell him to do that. Patient cannot do that. That means there's loss of coordination. Then I'll do the knee and ankle reflexes to also, and subsequently, and then I'll check for the tone. I'll tell the patient, I'll check, flex the hip, the knee, and the ankle, and then also and then I'll also check for clearness, and then I'll do leg rolling, and then I'll check for clearness. In patients with common peroneal nerve injury, I will expect that the patient will not be able to lift the knee against, the ankle against resistance on the right side for this patient. And then there will also be likely loss of sensation on the dorsum of the foot and or including the first interspace of eversion of the foot. I may also see presence of fasciculations, especially on the lateral aspect, on the anterolateral aspect of the leg, and then there may also be muscle wasting and high slippage gaits.
Right. Can you please present your case now?
Yes, ma'am. In order to complete my examination, I would love to examine the vascular system and check for pulse, and then also examine the spine and hip joints, the knee joint, spine and hip joints, and then And I've assessed this 56-year-old man who I noticed to have high-steppage gait. There was associated weakness of dorsiflexion of the right foot, with associated loss of sensation on this and on the anterior, on the dorsum of the foot, with loss of sensation in this, also including the first dorsal interspace.
So what are your differential diagnosis for this patient?
There's also presence of fasciculations and muscle wasting of the anterolateral muscles of the has foot drop pulse.
So what are your differential diagnosis for this patient?
Yes, ma'am. My differential diagnosis includes common peroneal nerve palsy, likely from injury to the common peroneal nerve following the radiofrequency ablation that he has had. It can also be sciatic nerve injury, and it can also be from disc compression of the level of the spine.
How would you confirm your confirm your diagnosis? What investigations would you ask for?
Yes, ma'am. To confirm my diagnosis, I would request for the patient to do an MRI. I would request for inflammatory markers. I would like to do routine bloods, paying attention to the inflammatory markers. I would request for hip and knee X-rays, and then MRI. I would also request for an MRI.
What are the treatment options or alternatives that you can offer to the patient?
Yes, ma'am. The treatment options, ma'am, they include I'll start with physiotherapy for the patient, requesting the patient to commence physiotherapy. I can also do electric nerve stimulation, and then I would encourage the patient to in surgically, I can also request the patient to, I can also further assess
Right. Thank you.
the nerve and
Yes.
do a nerve.
Dr. Samreen, I want to ask you something.
Severe cases.
Here is your question.
Yes, ma'am.
Just a second. That will go. Yes. Now, please, if you have read and understood, considering the critical care scenario, kindly tell me how would you manage this patient now?
I would like to give the patient IV fluids and also put her on left lateral position, so the gravity uterus move away from the inferior vena cava, and then raise her legs as well.
So what exactly would be your first next step?
Put her in left lateral position.
How would that help the patient?
It will lift up the gravid uterus from the inferior vena cava.
All right. Considering that this patient is pregnant and now patient has dropped her blood pressure, Who are you going to involve in the management of this patient?
I would like to involve the anesthetist, obstetrician, neonatologist if there is a preterm delivery, intensive unit registrar, and general surgeon.
All right, where are you going to manage this patient?
Obstetric HDU.
All right, can you please tell me why this patient is having a drop in her blood pressure? What is the mechanism behind it or the pathophysiology behind it?
Because of the compression of inferior vena cava by the uterus, it will decrease the venous return, which will decrease the preload in the heart, and ultimately the cardiac output will be decreased.
All right. How would you take care of the low blood pressure? What management would you do? Tell me specifically, please.
Firstly, I put the patient in left lateral position. Then I would give her the IV fluids.
Yes, how much?
And also I will give her the 20 ml per kg, 20 ml per kg, and in a bolus, and then
20
give
ml.
her
Okay,
inotropics.
Yes. Which inotropics would you give?
Inotropics can be adrenaline, noradrenaline, or isopropanol.
What measures would you do exactly at this moment to prevent further hypotension or further decreasing of blood pressure?
And further decreasing of blood pressure, I would give her fluids, inotropic, and vasopressors.
No. Patient is pregnant, so what's happening?
It's compressing the inferior vena cava, so I put her in left lateral position.
There's something more you'll do as well. Okay, can you please tell me, this patient right now, despite the fact she's 35 weeks pregnant, she has necrotic gangrenous cholecystitis. So what would you do? Would you operate on the patient first, or would you wait till she goes in labor? Which one would you do first?
We will operate the labor. We will operate the patient.
What if it endangers the life of a child, the fetus?
Yes, due to the anesthesia, patient fetus can go to the low fetal depression due to narcotics, and it can cause preterm labor as well, and fetal acidosis as well.
What is the mechanism behind it? Yes, what's happening? What, if you can tell me? And what are the prophylaxis or what are the measures that you can take from that happening?
Sorry, I didn't get your question.
Yes, I wanted to know the pathophysiology behind it, behind the mechanism.
Mechanism of intrauterine fetal death, or?
All right, can you tell me what is preload?
It's the end-diastolic volume.
Yes.
It's basically the volume of the blood that occurs at the end of diastole and which stretches the right or left ventricles of the heart.
Can you tell me how would the venous return differ when a patient, this patient, pregnant lady, is standing as compared to when she is lying down?
Venous return will decrease because the pooling of the blood in the lower extremities, which ultimately decrease the venous return, hence the cardiac output.
All right, can you please tell me how do you think this patient should be managed? Or she is already going under laparoscopy, laparoscopic cholecystectomy, and she is in Trendelenburg position exactly at this moment. So can you please tell me how would this pneumoperitoneum would affect her condition?
Yes, pneumoperitoneum can
On the tip of the
73.
fingers, tell me 4 things that it will affect. It will lower venous return, it will decrease cardiac output, then 2 more things.
It will low venous return, it will decrease cardiac output.
It will decrease functional residual capacity, it will decrease clinic blood flow. Okay,
Yes.
can you tell me which inotropes you told me once you'll give and on which receptors they will act?
They will act on adrenergic agonist or dopaminergic agonist.
Name few dopaminergic agents, please.
There are dopamine, dobutamine, diboxamine.
Good. Can you please tell me what is shock? Can you define the term shock?
Shock is a circulatory failure resulting in organ hypoperfusion.
How would the body respond to decreased blood pressure as a result of shock?
The body response, there is an autonomic response to decrease blood pressure by reflexes like baroreceptors, which stimulates the sympathetic activity, and then through hormones like catecholamines, which was released by adrenal medulla, which will in turn, and then then mineralocorticoids, which will increase, which will be which will in turn stimulate the renin-angiotensin-aldosterone cascade, and then ANP, and which is potent venous constrictors as well.
Okay, what are the reflexes which are involved in this situation that you are telling me?
Baroreceptors.
All right.
Baroreceptors.
Okay. They stimulate
the sympathetic activity, producing
Yes.
compensatory tachycardia.
Yes.
And
what are the
increase,
hormones responsible for that?
there is angiotensin, and there is
And?
catecholamines and
Yes.
mineralocorticoids.
Yes.
Mineralocorticoids, angiotensin, and
Tell me
aldosterone.
one last question, please. Tell me about the sympathetic and the parasympathetic supply of the heart.
Sympathetic and parasympathetic.
Okay, when in the exam condition you come across a question which you cannot answer, then say, I'll come back to this question at the end. Okay.
Okay.
Right. So, right. Tell me 3 things, last question, because you can answer this one. 3 things with the help of which you can improve the preload of this patient.
Preload of this patient can be increased by giving fluids, inotropics, and fluids, inotropics, and vasopressors.
Very good. You answered this one. Good. Thank you.